Hello, everyone. My name is Dr. Richard Horowitz, and I am the co-host of the Healing Lyme Summit 2.0 with Dr. Talks. It's my great pleasure today to introduce to you Dr. Bruce Patterson. Bruce is one of the leading researchers in the world on long COVID, and today we're going to be discussing updates in diagnosis and treatment of long COVID. So, Bruce, thank you for joining us today.
My pleasure, Richard.
Yeah. So tell me a little bit, tell people a little bit about yourself, how you got into this for immunology. How did this whole thing start, since you seem to have been playing a big role kind of leading the way now for some of these new treatments?
It's a really interesting path when I take a look at it because I started in HIV in the late '80s and early '90s, and one of the major emphasis of my research was looking for hidden reservoirs of the HIV virus. At the time, they were even thinking that maybe HIV wasn't due to, or maybe AIDS wasn't due to HIV, that maybe it was a super antigen effect or something else. So, it started my journey on sort of the reservoir search, and this being our fourth pandemic, my fourth pandemic. I kind of knew where to look, and I think that's where we've gotten to where we are, and now including our newest data on Borrelia and Lyme. I think I'm going back to the old bag of tricks and looking for underlying mechanisms for chronicity in all of these post-infectious conditions.
Mhm. Yeah, so at this point, the reason I think our talk specifically is quite important is the dapsone protocol that I'm using for chronic Lyme is effective in the large majority of people. There's no doubt that these persistent biofilm forms of Borrelia are causing a role in chronic illness, but we are finding long COVID specifically through, InCell DX, your lab, Radiance Diagnostics. We're finding it along with mold toxins with Babesia and Bartonella kind of overlapping a lot of these patients. And if they don't seem to get treated, or if they get a partial response from dapsone, partial response treating the mold, it seems like the viruses may be playing a role kind of underlying. And years ago, we would find some viral reactivations with EBV or HHV6, but now since long COVID's been hitting, we're seeing a lot more viral reactivation than we were from before.
And our new data is now suggesting that it doesn't even have to be reactivated. We showed in long COVID that the actual viral proteins and fragments of RNA were sequestered in non-classical monocytes through scavenging, or phagocytosis. We found that with long VAX, if you will, where we also found the S1 spike protein in their non-classical monocytes, despite the fact that they were never infected. And then, the clincher being just from the last, four weeks or so, we found Borrelia protein in one of the patients in our study had Lyme 20 years ago. We found Borrelia OSP-C and flagellar protein in their non-classical monocytes. And we're doing the transcriptomics now, but it looks like there's no transcriptional activity of the bug, and the bug may not even be there. There's some really interesting data on Borrelia in vitro on monocytes where they cultured monocytes in a flask. They added in live Borrelia and got immune activation as one would expect. But what was really interesting from that data that really wasn't pursued was the fact that they could put heat inactivated Borrelia on these monocytes and got even more immune activation. Again, liberation of IL-6, interleukin-1 beta, TNF alpha, all the usual suspects in a monocyte activation condition. And heat activated Borrelia proteins even did more activation than the live bug. And that's what we're working on right now. We found that in chronic Lyme patients. So in addition to biofilms and some of the other mechanisms that you mentioned, I think there's a new one. And that's what we're writing up in our new paper, is that there's a new mechanism for chronic Lyme. And that may be the fact that you can harbor Borrelia proteins in your non-classical monocytes for years, if not decades, in the absence of replication, which may be why
Well,
they're
Bruce,
resistant to.
question, how are you proving that you haven't scanned the entire body? I mean, look, most of these patients that I see, it is a chronic persistent infection. Now, they've published on peptidoglycans before. that some of these proteins can obviously get in between the cell layers and stimulate immune reactions. But at least from my perspective, it's not going to be an either or. It's going to be kind of everything all together. But, just like they just published a couple of days ago that they found some of the spike proteins, so I saw in the bone marrow of the skull, right, in the meninges. I mean, they're finding these spike proteins. I
Yeah.
don't doubt that you'll find some, inactivated Borrelia in some places. But honestly, in my case, because I've been doing this for 40 years with 13,000 people, it's an active infection in most of these people, but it doesn't mean it still can't be some of what you're describing. Like they could have a very low load of Borrelia. Borrelia is not like syphilis, right? It doesn't have a high load. You may still find some pieces of the bacteria stimulating with only even a couple of live spirochetes someplace else in the body. So I don't think it'll be either or. I think it'll probably be both.
Yeah, I absolutely agree with you. The one caveat is that this particular cell type, number one, becomes long-lived when it's presenting antigen, and it also has a propensity for blood vessels. And the one thing that I'm seeing that's common to long COVID, chronic Lyme, chronic fatigue syndrome, fibromyalgia, is they have this pattern on our cytokine profiling of vascular inflammation. The SCD40L, the CCL5, the VEGF, and other inflammatory proteins that are being liberated by vascular inflammation, platelet activation. And in particular, we showed in a paper last year that these particular cytokines can be correlated with symptoms: headache, migraines, brain fog, ringing in the ears, temperature. If you ask some of your chronic patients, are you cold when you shouldn't be cold, or hot when you shouldn't be cold, shouldn't be hot? They're going to say absolutely. And it's because their blood vessels are dilated and they can't regulate body temperature. Similarly, because they're dilated, they have periods where they drop their blood pressure and their heart races, so-called POTS. To me, POTS is just a symptom, but you relieve the inflammation. In fact, on our regimen, one of the first symptom complexes to go away in 3 or 4 weeks is POTS and temperature dysregulation. So I think it's this particular cell. Yes, absolutely. Can we find it in tissues? For sure. But you know what? It's this particular cell type that has a propensity to spew out inflammatory cytokines and its propensity to bind to blood vessels that I think is particularly pathogenic.
So question for you, because I'm using your panels kind of all the time at this point. And in fact, I was just discussing with you a few days ago a patient whose CCL5 Rantes was negative, but the SCC40 was positive, the VGF was positive. How do we know in these patients that it's the COVID spike proteins that are actually driving it versus Bartonella or both, or multiple factors driving it? Have you able to come to any conclusions? Because we use VGF as an indirect marker of BART. It's been associated in the literature,
Yeah.
but obviously you don't know where the vascular inflammation is coming from.
Right. And, at the end of the day, sometimes I tell patients, I don't care. All I know is this is causing your symptoms, if I take care of it. But in reality, um, you could have spike and you could have, obviously tick-borne organisms. But you know what? I don't truly believe there's an overlap syndrome, because what happens is when you have acute COVID, and we published this way back in 2020, you are supremely immunosuppressed. I saw patients dying in February 2020 of CMV, which I hadn't seen since the early days of HIV/AIDS. Their CD8 counts are as low as the CD4 counts in HIV. And even with the newer variants that don't seem to be as severe, you still get low CD8 counts. So, of course, as you inferred, the chronic herpes family viruses reactivate. If you had undetected or inadequately treated, Lyme or co-infections, they come out to play. And you know what? They all cause the same symptoms. So it's very interesting. But we have a test that detects the spike protein in all the monocyte lineage cells. That's now commercial. So I'll use that if I see something unusual in terms of the cytokine patterns, and like for instance high IL-6, which is very atypical. I think in long COVID relative to acute COVID, then I'll go look for spike protein in the monocytes. And yes, I may see spike protein in the monocytes in somebody who has a past history of Borrelia, Bartonella, Babesia. So yes, I
Right.
think there could be a multitude of factors going on. In fact, at iLads, I called this cell type the human garbage can because
Uh-huh.
we've only looked at three instances of sort of protein fragments in these cells. But I know these cells for a fact, since I worked with them, are infectable by HIV, by Zika virus, dengue fever, and truly, I think they scavenge. I think they're a garbage can, and that leads to ongoing long periods of immune activation. And at the end of the day, we got to empty the garbage can.
Right. So, and by the way, regarding the immune problems, we know that there's T cell exhaustion with long COVID, and we definitely see the
Absolutely.
CD4, CD8
Yeah.
counts drop. Natural killer cells are oftentimes
Yeah.
low in these patients.
Yeah.
Their B cells are also affected when they get Lyme and Bartonella. So, I mean, essentially, we're dealing with people with chronic variable immune deficiency, subclass deficiencies, and T
Absolutely.
cell deficiencies, and it's no wonder,
Absolutely.
right? They're
Yeah.
getting so sick with all of this because
Yeah.
they've got mold toxins
Absolutely.
on top of the infections, on
Everything.
top of spike
You
proteins. I
bet.
mean, yes. There's
It's
a lot
it's
of things keeping
everything.
them ill.
Yeah, there is a lot of things. And you know what the other thing is, um, you know, we no one does it clinically, but if you look for exhaustion markers, PD-1, TIM3, CTLA4 on T cells, I mean, they're these cells are exhausted, So, and we published that in 2020. There was lower T cell numbers, especially CD8s. There was T cell exhaustion, and the T cells weren't making granzyme A. So, there's three reasons for them to be completely exhausted and not doing the job that they should be.
Right. So question. So in the testing that you're doing through Radiance, when we get it back, um, it's interesting because a lot of my patients, when they've done dapsone combination therapy, we know that when you turn on TNF alpha, when you turn on NF kappa B and you get TNF alpha, IL-1, IL-2, IL-6, on your panels, it's true. I'm not finding a lot of TNF alpha and IL-6 on your panels. What we're mainly seeing a lot of times is the CCL5 rantes, the VGF, the STC40. Are you finding that in a large number, or are you seeing some of these active Borrelia patients with the IL-6 and TNF alpha? Are you seeing a mix of this when you're looking at it?
Yes, and in fact, in the paper we published in August on a long COVID diagnostic with differentiation from chronic Lyme. In fact, the Lyme index, which we'll be launching clinically here probably in the beginning of the new year, the numerator of the Lyme index was interleukin 4 plus TNF alpha. So yes, TNF alpha in the truest sense is a marker that leads us more towards a Lyme diagnosis than a long COVID diagnosis. But you have to also differentiate between a Lyme diagnosis and acute COVID, where you do see the interleukin 6 and the TNF alphas because of the immune activation. But we don't see that much anymore because usually people have been either exposed to the vaccine or exposed to the virus multiple times. So your adaptive immune system has kicked in, and you're no longer, the first wave was just all innate immunity. So of
Mhm.
course you saw the interleukin 6 and TNF alpha really taking a dominant position and doing a fair amount of damage in addition to trying to fight off the virus in the
So,
early days.
this begs a question, and I don't want to get into vaccine controversies too much, but it does beg the question whether the Novavax vaccine, which is a different type than the messenger RNA making spike proteins, if we're now finding spike proteins in, bone marrow of the brain and meninges and all over the body, should we be going back to more of a classical? I mean, obviously, I've gotten vaccinated and my patients have gotten, and not everybody gets sick. I've seen some patients reactivate after the boosters. Fortunately, not that many after they've gone through Dapsone. But it's a question, do we have any way of like knowing which people are going to be more sensitive to getting spike proteins, whether from the vaccine, whether from the virus itself? Is there any way to differentiate? I don't know that we can at this point, but it's a question. Other people have even brought up other retroviruses that even transform some of this, right? And that's a big question that no one's answering. That it's a big one for the literature.
Yeah, it's a big leap. Again, like I said, one of the reasons we developed a spike protein, not a spike antibody, but a spike protein test, and found obviously this reservoir, which now serves as a great marker, is to be able to answer those questions. Are you retaining spike? And certainly, we see it when patients have symptoms. We do see patients who've never been infected by COVID who just got vaccinated and have spike protein in their monocytes and have long COVID symptoms. In fact, it's one of the things that I rely on to say you don't need active viral replication to have long COVID.
Mhm.
And I've said this all along, and there's no way you can prove with patients getting infected 5, 6, even 7. I have one patient 7 times has had COVID.
I
How can
have
you
I have one
tell?
also, by the way, 7 times.
How can you tell if you find active virus, oh, that was the one that caused long COVID 4 years ago, or it's one from last week? And we did it with not with whole genome sequencing, in our first persistence paper, where we showed there was no complete genome. I mean, yeah, you could get partial transcription and everything, but you know what? You never could make a new viral particle with 5% of the genome represented. We showed that in tissue of long COVID patients as well. So, our what we would say is you can't make a building with 5% of the bricks. But nevertheless, we found this mechanism where you don't need active replication. And that's what we're pursuing right now with our new paper on Borrelia is, you know what? We don't need active replication to cause symptoms and to cause chronic inflammation.
So question on this regarding the virus because there have been studies showing that sometimes the virus, right, can persist, like causing inflammatory bowel, right, where they found active virus in parts of the body. Your cytokine panels and chemokine panels have a way of telling how many are just pieces of the virus, how many are active virus. Any way to tell at this point?
So our first paper, which I don't think people quote enough, is that we showed with 2 algorithms a completely separate population of patients who were indeed long COVID, and we did it without any bias towards symptoms. And then we found the ones who had either mild acute or severe acute COVID through what we call the severity score. So yeah, we know which ones have a immune response that is consistent with active replication. But the fact is, how are they proving active replication? Not by PCR, not by in situ hybridization. Only way to do it is to sequence or to grow it. Because we caused a stir in our first paper when we found using droplet digital PCR, which is supremely sensitive in plasma of acute COVID patients, we could find virus. And of course, all the blood banks in the world called me and said, do we have to worry? Much like this reminded me of the late 80s and HIV. Do we have to worry about COVID being transmitted by blood? And so we collaborate with a number of different groups. We took the plasma from these patients who had virus detectable by digital droplet, and we could not grow it. The best virologists in the world couldn't grow it. We couldn't grow it, and you know what? Whole genome sequencing was spotty. We didn't get whole genomes, and that's the kind of work that has to be done to make that huge leap of faith from persistence to replication competence.
Mhm.
The problem is, I think the world interchanges those, and that's wrong. Okay, yes, I agree there's persistence. You can find fragments of S1, you can find fragments of RNA. Any tissue you look at, no questions asked. Whether or not it can actually make a new viral particle, I have supreme doubts that it can,
So that
unless it's a brand
right.
new
So
infection.
right. So that part is not proven at this point. Even in the ones who get all of a sudden inflammatory bowel with Crohn's and ulcerative colitis, it's not clear whether there actually is again, just pieces of the virus are active. I mean, we are finding a lot of EBV PCRs in the blood, HHV6 PCRs. I mean, that
Sure.
we're definitely seeing. There's
Yeah,
no doubt
no
about it.
doubt. No doubt. But you know what? Now that we're showing this new mechanism, I think it's a new mechanism in immunology where the fragments of protein and maybe even the fragments of nucleic acids are sufficient to cause an abnormal and a deleterious immune response, I think we're into a whole new arm of immunology where, maybe autoimmunity is caused by these retained proteins. We never found it because we are doing genomics and everything, right? So, I think we're only at the tip of the iceberg in terms of chronic inflammation and what those underlying mechanisms are. But you know what? From now until I'm done doing research, which I don't know if I'll ever be, I'm looking for non-replicative reasons why we have chronic inflammation from past infections.
It's interesting because you're quoting that. There was mice studies that were done years ago when they were looking at xenodiagnostics, and they found in some of the mice with Borrelia that they had what looked like initially non-replicating forms. And then eventually they found that some of these forms actually were replicating later on, but they were dormant in the body. In these cases, they were probably biofilm persisters they were looking at. But as I said, I think it's going to be all of the above. I have no doubt because peptidoglycan's been talked about years ago. I think,
Yep.
from my perspective with the inflammation, the bees for me, the Borrelia, Babesia, Bartonella are on the top of the list with toxins like mold and metals driving
Yeah.
inflammation. And then they get
Right.
leaky gut and food sensitivities with mast cell activation and microbiome issues. They're not sleeping, so their IL-6 is high. They got vitamin mineral deficiencies. And
Yeah.
then they have all the downstream effects of these free radical oxidative stress with mitochondrial
Yeah.
dysfunction and hormone dysregulation and HPA axis, like you're talking about. They can never get, they're cold, they're hot because their hypothalamus is affected by.
Yeah.
So
Right.
there's
Yeah.
a lot of causes
There
of why
is.
the inflammation is there. I think what's important, and we'll see this because I'm about to start a randomized trial, hopefully also on dapsone by the end of next year. We're applying for NIH trials. And by the way, not that I have to speak to you today about it, but we plan on using your profile
Oh,
in
great.
studies we're going to be doing because we have to figure out when I'm going to be looking at a dapsone randomized trial, the things that are interfering most with the success of what I do is
Right.
active babesia, day sweats, night sweats, chills, flushing, air hunger, unexplained cough, Bartonella, pain in the bottom of the feet, these striae that are changing colors and moving
Right.
around the body, severe
Mhm.
neuropsychiatric symptoms with POTS. We find a lot of active Bartonella species. But
Right.
then we've got long COVID kind of following right behind with mold. And
Right.
so we're dealing with all these immunosuppressive things that I have to figure out in a trial to look at chronic Lyme, how I'm going to
Yeah.
separate out these different things.
Right.
I don't think it's easy because we see
No.
so many overlaps. I just have to figure out
Right.
what would I do in the trial to eliminate the worst long COVID cases. I think
Right.
everybody at this point is going to have some exposure. Would you at this point say they should not have a CCL5 Rantes or an SDC40? Like, how would you, if you would just wanted a pure trial for active replicating Lyme, active, what would you leave out of the side? What would you not want to see on your
Right.
panel in my trial?
Well, funny you should ask because we're doing the exact opposite for our trial.
Yes.
So, we're enrolling the patient. So, to answer your question, long hauler index has been so robust for us in determining who's got long COVID and who doesn't, unless it's over 6, where that's almost 100% Lyme. Okay, and so we're doing the same thing to rule out Lyme and EBV reactivation in our long COVID trial because we want a pure population of long COVID. Everybody's lumping everybody together and they're saying, oh, well, 28% of my long COVID patients had EBV. That's not long COVID, right? You can call it PASC, which is post acute sequelae of COVID. That's fine, but it's not long COVID because the SARS-CoV-2 virus is perfectly capable on its own without EBV, without Lyme, of causing a post-infectious condition,
Mhm.
right? So we're doing the same thing. I'm ruling out Lyme. So if I see elevations that in my 3 bullet points for Lyme, elevated interleukin 8 plus interferon gamma, interleukin 13 plus interferon gamma, or a long hauler index greater than 6, they're getting excluded from our trial. And because of something else, we're doing EBV DNA PCR for EBV, not serology, because I think it's difficult, if even possible, to say whether or not there's reactivation of EBV on serology. But we are doing the exact same thing from the other angle, and I think it'll work out well for you. And all I would look for is a long hauler index. So
Really? So in other words, just if the long hauler index is
yeah,
high.
it
Look,
it
and
really
so
has
you're
nothing
talking
to do
about
with
interferon gamma, IL-4. You including VEGF there then when you do
so long hauler index is IL-2 plus interferon gamma over CCL4. So you can
obesity?
imagine in Lyme, which has extremely high interferon gamma, that you're going to have really, really high long hauler indexes. So when I see a long hauler index greater than 6 or even nearing 6, I reflex to tick-borne diagnoses. So that's what I'm looking for. And long hauler index is actually interleukin 2 plus interferon gamma over CCL4. You know what? Rantes, yes, is important. It was extremely high early on in acute COVID. But you know what? Maraviroc, the CCR5 antagonist, targets so much more than Rantes. That's the obvious, right? But there's papers direct lowering of VEGF by CCR5, okay, antagonists. Direct lowering of SCD40L by atorvastatin, which is our combination. Direct lowering of interleukin 6 and TNF alpha by Maraviroc because it repolarizes the pro-inflammatory monocytes. So it's so much more than just kind of blocking CCL5, which is obvious. So I don't. That's not a criteria for me to choose therapy. My criteria for choosing therapy is number one, this triad of vascular inflammation, SCD40L, CCL5, and VEGF, or signs of monocyte macrophage activation, interleukin 6, TNF alpha. So that's my criteria.
So going back to BART for a second. So, we can't always find most of our patients have some Bartonella immunoblot showing pyroreactivity. Their BART fishes aren't always positive. We don't even bother with. If I could do direct droplet PCR from Galaxy, I would love it, but in New York, I can't get it. How do you know when you're using Maraviroc and you're going after VEGF in that point? If let's say BART is hanging around in the background, and it's tricky because there's so many species,
Right.
you'll be lowering down the vascular inflammation, but if the cause of the vascular inflammation is still there, right, the BART may just still be there and cause it to come back months later. You're gonna account for that in the trial?
No, you're absolutely right, Richard. And we you as I tell my patients, I'm like, you have to treat the bug and the immune system. It's the immune system, as we showed last year in our publication, that's causing the symptoms. But at the end of the day, the bug's driving the symptoms. And if the bug's still active, you're running your head, you're hitting your head against the wall.
Right.
So you have to treat both. And again, we're going to do some screen. We'll probably do if we see even a suggestion or an elevation of VEGF, we won't just pass it off. We would probably then go on to screen those individuals for Borrelia, Bart, and Babesia before we enrolled them.
Yeah, you'll probably find. I mean, BART, the marker for BART for the VEGF, being apart from cancer things, of course, God forbid anyone
Yeah,
came in by accident, but
right,
the VEGF, I would say it's probably not more than maybe 25% of our patients with BART at some
right,
point, the VEGF goes up, but we have seen it as a marker and then we treat it and it does go down and they're better.
right,
But definitely the long COVID pieces, it's created a monkey wrench for me in the last couple of years because we were having
yeah,
such great. And by the way, what's interesting about Dapsone, which I have to prove, it's an anti-inflammatory, right?
right,
It decreases myeloperoxidase. It does a whole bunch of used for autoimmunity. There are people
right,
that will argue, well, how do you know you're just not lowering inflammation, like with Maraviroc, for example, working on specific pathways? The only reason I think it'll show it separately is because we're going to use other persister drug combos, like we'll use rifampin and methylene blue and other persister drugs without dapsone in one arm of the trial to see if
right,
we can see a difference in the results. But yeah, just
right.
be careful. Bart is showing up in the vast majority. I just look, and by the way, I'm happy to look over it before you go forward with this. If
Yeah,
you want to send me over and just brainstorm with
yeah.
me, just like I'm going to brainstorm with you, but before I get my trial
Yeah,
into place.
absolutely.
Yeah.
Because I mean, you get one shot at these things, and you certainly don't want to make that mistake. So, yeah, I mean, I think as our trial comes together, our primary outcome is a fatigue score, and the secondary is a dysautonomia score.
Mhm.
But so we'll start having presumptive enrollment based on a certain fatigue score. Then we'll start ruling those patients out, and that's when your phone's going to ring from me,
Great.
asking if we've gotten rid of those. But you know what? it's conceivable that we could get a couple, but we don't know.
Yeah. So why don't you just tell people? I mean, you and I, of course, know about Maraviroc and atorvastatin or pravastatin, but just for the group, why don't you just talk about? There was an article that just got released about, I don't know, maybe 2 weeks ago, with
Yeah,
hundreds of variables that they were finding in long COVID and these chronic fatiguing illnesses. Maraviroc was one of the ones on there. So was glutathione, by the way, that I did see the p-value actually looked pretty good because
yeah.
we published the first article on low glutathione and COVID in April 2020. But why don't you tell people about the dosing, what you're seeing using this, and what they might be able to expect?
Yeah, I was really excited about this article from I believe it was from Stanford and Harvard on patient-based responses to various interventions for long COVID. There's probably like 15 of them, and yeah, Maraviroc had the highest rate of significant improvement in patients of all the different interventions, and it was also the only one that didn't make patients significantly worse in some instances. So yeah, we were very pleased by how that came out. And of course, it was compared to, pacing and IV fluids, which is just, you just putting a band-aid on symptoms. And but ADHD medicines, LDN, glutathione. I mean, everything under the sun. I think it was really well done. And it came out as a leader in terms of significant improvement. And, we stick with the 300 milligrams twice a day of Maraviroc dosing because that allows us to go through the 505(b)(2) path of the FDA since the drug's already been approved for other indications. And then statins are extremely important. As I mentioned, it directly lowers SCD40L, and it also lowers a protein called fractalkine, which binds these pro-inflammatory monocytes to the blood vessels and to the blood vessel wall, where they then extravasate into tissues and bring their inflammation with it. So um, it's a really great combination. And on top of it, Maraviroc, of course, repolarizes the pro-inflammatory monocytes, keeps them from migrating all over the body. But the other function of Maraviroc, which is key, is the lymphopenia, post-infectious lymphopenia is a CCR5 dependent pathway. And when we noticed early on in 2020 that Maraviroc was increasing lymphocyte count in patients who had low lymphocytes and increasing CD8 T cell counts in patients who had low CD8 T cells, which was almost all of the long COVID patients. So it's got a really exquisite mechanism of action. But there's still people who think it's an antiviral or antiretroviral, and nothing could be further from the truth. So that works out well. And you don't need a lot of statin. I think that's the other important thing about our protocol is we're not trying to lower cholesterol. We're trying to lower inflammatory proteins related to vascular inflammation. And so we'll go with low levels of statin. So we don't have patients who have a lot of side effects. Sometimes we'll add in colchicine when patients aren't progressing fast enough. And
By the way, what point would you do that? It's normally at least a 12-week protocol, correct?
It's a 12-week protocol. If they've plateaued, at 8 weeks or so, or they're not progressing as quickly as we would want them to, then right around the 6 to 8 week mark, we'll add in zero point 0.6 milligrams of colchicine, and that is a real kicker to get them across the finish line.
Great. Right. And of course, for those of you who don't know colchicine, it's a very old drug from 50, 60, 70 years ago for gout,
Yeah,
but essentially has anti-inflammatory properties.
absolutely. And it does that has a little bit of GI side effects, but the Maraviroc and statins really don't do
Yeah,
much of
we
anything.
haven't really seen a lot of side. I mean, I have occasionally
Yeah,
sensitive patients, but for the most
yeah,
part, even though it's a low dose of statins, like 10 of atorvastatin or 10 or 20 of Prava, do you
right.
still use CoQ10 with it, or you don't even bother?
I don't, you know what? I don't care. Yeah, I mean, I usually have these patients come in with laundry lists of supplements, and really, there's nothing. I'm fine with them taking the supplements, especially CoQ10. And you know
Well,
what? Why
statins
not?
have been shown to lower it. That the reason I'm asking is they've
Oh
been
yeah,
shown.
for sure, for
Yeah,
sure. But
yeah.
in 6 to 12 weeks with a low dose, I don't think it's necessary. But
Okay.
you know what? I'm also not going to try and dissuade anybody from taking them.
Now, so what happens? So if someone gets to 12 weeks, and they have not improved the way they would, or you would expect to, do you then go back and go, well, gee, if it's not just long COVID, maybe there's other factors driving inflammation. Like, how does it work as far as the protocol, the way you're looking at it?
For sure. And if they get to 12 weeks and they aren't progressing, um, with pure long COVID, that really doesn't happen. But certainly that's when I start looking for other things,
Got
looking
it.
for, tick-borne, looking for some chronic herpes family viruses. And now, I've been trying to get this study with Neil Nathan off the ground. Where we're going to look at mold. I start looking for other things in these patients. And that brings up another point in terms of mold is, with our 14 biomarkers that span kind of many different arms of the immune system, there's 89 billion different combinations of those. And my biostatisticians are the ones who've developed all these algorithms for long COVID, for chronic Lyme. And I think we're anxious to develop an algorithm for mold. Funny thing happened when we were developing an algorithm for ME/CFS is they did more or less like a tree, basically like you do with genes or gene sequences. They did a tree of immunotypes. And ME/CFS we found is at least five different diseases, five very distinct different diseases with distinct.
Immune profile is completely different when
Yes,
you're looking at them.
we have five. We're working right now on what defines these five immunotypes, and it may be more than five immunotypes. But to say ME/CFS is one disease is now not part of our thinking.
No, and of course, the problem with patients is the symptoms of ME/CFS and fibromyalgia and long COVID and chronic Lyme overlap, as does
Right.
mold, in fact.
They
So
do.
the difference with Lyme is usually the symptoms are coming and going with good and bad days, and migratory joint pain, migratory muscle pain, or migratory nerve pain, the tingling, numbness, stabbing, burning, that's classic for Lyme. It
Yeah.
may also be an overlap with BART because when we first did our study and published the statistics in 1,600 people, when we did this in 2017 with the State University of New Paltz, there was no way of knowing how many people really had BART because we didn't have good BART fish testing at the time
Right.
to know.
Right.
So it may even be a part of BART also. But that's the only way I can differentiate, honestly,
Right.
whether Lyme is there versus these other diseases and whether it's being driven by other bacteria, viruses, parasites, even fungi. I mean, the inflammation can come from multiple sources.
It can. And Richard, I'm with you. Those last three conditions that you mentioned really steer me towards, Lyme or the co-infection, which is joint muscle pain, paresthesias, and certainly the striae in Bartonella.
So, Bruce, other questions. A lot of researchers and doctors out there who are talking at this point about platelet activation. They're finding, the virus in the platelets or pieces of the virus with platelet activation. They're using nattokinase. They're saying these microclots. We've got to open up the microclots to be able to get to it. There's vascular inflammation where they're using arteriosol or other things, for the vascular inflammation. And you mentioned LDN, mast cell activation. People are using PA-luteolin. There's a lot of things out there that people are trying at this point. When you looked at that study, I still need to go through it because there was so many p-values all over the place. I need to look at it. Is there anything else you're finding when you've looked at the literature about these idea of there are these microclots holding on to pieces of the virus with the endothelial dysfunction, with the mast cell activation? You finding anything in there that is showing up in your research?
You know what? The great thing is it's all in this paper. If you want to look at the efficacy of nattokinase, it's right there in living color. So and we'll stand by that data. But we're really not. And you know what? The more time goes on, out of 12,000 patients, we haven't had a single one with a clotting event. And you know what? It's because we immediately get them on statins and lower SCD40L, which is the first protein in the thrombotic pathway. So, and we essentially relieve the platelet activation using a combination of maraviroc and statins, and all those markers tend to go away. But you know what? I don't. And being a laboratorian, I'm very cautious about microclots. I mean, you take blood from anybody who has inflammation, you put it on a slide, it's going to clot. If you run any blood through microfluidics, where most of the diagnostics these days are microfluidic, you form microclots. And then when I saw pictures of them, some of them look to me as pathologists like these epithelial mesenchymal transition cells or EMTs. They're common in cancer, but I think they're also common in chronic inflammatory diseases, especially ones where there's tissue damage. And basically what happens is epithelial cells from organs binds to monocyte macrophage lineage cells and forms this kind of glob in the blood. And we could see them when we were detecting circulating tumor cells. But you see them, these EMTs, they stain for everything because the monocytes just phagocytize antibody. So the non-specific staining is ridiculous. So I have a really hard time believing in that. And like I said, none of the anticoagulants ever worked for us when we tried them 3, 4 years ago. And like I said, our protocol keeps working. So, I don't know that any of these things, we described our mechanism for endotheliitis now almost 3.5 years ago. And I'm not, we haven't really ventured far from that because I think, for everything we can see, it's working, and we have a non-subjective means to show that it's working.
So the only reason, by the way, I don't think we have seen microclots is because everybody in my practice has been on N-acetylcysteine with glutathione. It turns out N-acetylcysteine lowers von Willebrand factor. I didn't
Yeah,
realize it at the time, and that was, of course, an issue with the early COVID viruses with the variants, right, where people were
yep,
dying of those clots. It's true
right,
with the latest versions and the variants. I don't know if we're seeing it as much. It's very difficult to compare
yeah,
some of these
right.
people who had long COVID from the initial variants from Alpha from what's going on right now.
Exactly. And you know what? I mean, we saw a lot of clot, and there's no doubt clots were happening in the acute phase. There's no doubt about that. I just think that, 90 days later and in long COVID, we just didn't see a lot of it unless they got reinfected, of course. So, and that's always the specter, is this reinfection. And yeah, there was this window of this, someday when the book's written, between February 2020 and June of 2020 was a hot spot for long COVID. And someday when we have time, we may go back and look at our samples from then and try and figure out why that was. I know in our persistence publication, we showed that in some severe acute COVID cases, we started to see spike protein in intermediate monocytes and some in non-classical monocytes. So we're starting to establish a reservoir of protein in the monocytes in some of these severe acute cases, but we haven't really pursued it to date with now that we're on the precipice of this trial.
Great. And how many people are you planning on enrolling in this trial that's going to go forward?
So it's 252 patients, 3 sites. We'll be making an announcement here in the next few weeks. And everything's ready to go. The drug's being made as we speak. And, it should take right around 6 weeks. So sometime, by the beginning of summer. And we have an 8-week interim analysis. So we'll have a good idea of how it's going.
That's great. Well, congratulations on getting this done. And so for Bruce, for people that want to contact you that may have questions or want to use IncellDX or Radiance, how do they get in touch with you? What's the best way to do that?
Yeah, I think the best way is the www.health healthbioai.com. And of course, obviously Bruce P at insultdx.com is how most people get it. And I can announce it because everybody uses it anyway. But yeah, you can
Right,
get a
that's
hold of
like me
us, or
trying to
else.
keep my private email private at this point in time. Yeah, I'm
Yeah,
well aware.
exactly. Yeah, no, I have, yeah, another family email, but and then of course the Chronic COVID Treatment Center, which is COVID long haulers with an s.com, is how patients can enroll and visit with our team of physicians, and we'll manage them. So that's how to get a hold of us.
Great. Well, thank you, Bruce. This was a great talk. I think people are going to get a lot out of it because this is it's an overlap we're seeing in our chronic Lyme
It
population.
is.
I think you're doing really essential work here. So I want to thank you for being on those front lines and exploring
Thank
it,
you.
just like I've been exploring the biofilm
You
persisterol.
have.
Everybody's
You
got the
have.
place, and all of this is going to come together at some point in time.
No, I
There's no
I
doubt
enjoy
about it.
these conversations because we can kind of synthesize the first attempts at putting this very complicated issue together. So I
Yeah.
really appreciate it.
Yeah. So everybody, again, you've been listening to Dr. Richard Horowitz. I'm the co-host of the Dr. Torek Healing Lyme Summit 2.0. You've been listening to Dr. Bruce Patterson. Bruce has, again, been one of the experts on the front lines with long COVID. Bruce, again, thank you for taking the time today,
Pleasure.
and we'll see you again for another episode soon.